Hi, I'm Ghamar Bitar. Welcome to this week's Pocket Pearls. Hi, welcome to Pocket Pearls. My name is Ghamar. I'm a second-year resident at Christiana Hospital. I'm here with my co-residents, Adrian and Yaniv. We're here to talk about the ARRIVE study.
So what's the ARRIVE study?
So the ARRIVE study is a randomized trial of induction of labor versus expectant management. It was a study done over the last 3 years, from 2013 to 2017. It was an unmasked randomized control trial that either randomized low-risk nulliparous women to induction of labor at 39 weeks or to expectant management.
Hasn't that been done before?
Not exactly. Previous studies have looked at elective inductions of labor versus spontaneous deliveries, which isn't quite a fair comparison. So the recommendations that are out there are based on these previous studies.
Okay. So what are the recommendations now for induction of labor for nulliparous women?
So the recommendations for induction of labor of women who've never had children before are based on the ACOG practice bulletin that's very well known, the induction of labor practice bulletin. This practice bulletin states that you should counsel your patients that within an elective induction of labor, they're at twice of an increased risk of cesarean section. That's why the ARRIVE study is so important, because it can provide us with more information about this.
So they only looked at nulliparous women?
Yeah, so the study only included low-risk nulliparous women. What that meant by low risk is that these women had no indications to delivery prior to 40 weeks and 5 days. That meant no fetal or maternal indication for delivery, like hypertension in pregnancy.
Do they look at perinatal outcomes at all?
Perinatal outcomes are actually the primary outcome of this study. They looked at a composite of outcomes including perinatal death, respiratory support within 72 hours after birth, APGARs, HIE, seizures, and other things as well.
So you mentioned C-sections before. Did they look at other maternal outcomes?
Yeah, so they actually looked at C-section as their primary maternal outcome, and they did subgroup analysis based on many other things, including age, race, or ethnic background, modified Bishop score.
So what did they find out about the babies?
It actually showed no statistical difference in the primary composite outcome, looking at perinatal mortality and looking at severe morbidity.
So babies in the expectant management group did the same as babies who got an elective induction of labor?
That's a great question. They found no differences in the other neonatal outcomes, except there was a shorter amount of respiratory support and a shorter length of hospitalization in the babies who were in the induction group.
So we currently counsel patients about an increased risk of C-section with elective inductions. What did the study find?
That's a great question. So the primary maternal outcome for this study was looking at cesarean rate. They actually found in the women that were induced at 39 weeks, those women had a lower rate of C-section as compared to women with expectant management. What they also found in the women who had an elective induction at 39 weeks was these women were less likely to have hypertensive disorders of pregnancy and to have uterine extensions if they did have a C-section, and they were more likely to report less pain during their delivery process and a more perceived notion of control. And surprisingly enough, there was no other differences noted by maternal age, BMI, ethnic group, or even modified Bishop score at randomization.
So we primarily do Foley, bulb, and pit inductions here. Did the type of induction matter in the study outcomes?
No, it actually didn't. They used many different induction protocols with Pitocin at different settings, including community and academic centers.
So now that we know that babies do just as well with elective inductions of labor compared to just expectant management, and moms have lower rates of C-section, should we change the way we counsel our patients?
You know, that's a very interesting question. I think what's important now is that we have the option of counseling our patients for elective inductions at 39 weeks. Not all of our patients will be candidates for an elective induction at 39 weeks. What ACOG currently recommends, by a statement that they put out earlier in August, is that we have a frank conversation with our patients about the risks and benefits of an elective induction, and that not all patients will want an elective induction. And so it's really going to be a give and take between the provider and the patient. So the takeaway of this study is that if we induce nulliparous women at 39 weeks, they have similar perinatal outcomes as those who we expectantly manage. They also have a lower rate of C-section. So you can counsel your patients appropriately and have a conversation with them about their options.
They looked at a composite of outcomes, including perinatal death, need for respiratory distress. Shit.
Nobody needs respiratory.
Previously, the studies that looked at
I'm sorry.
I see her dying. Can you do this together?
Okay.
this is not my fault.
No, start from the beginning.
No, I'm gonna
Yeah,
start.
start from the beginning.
He can
You
just
don't
cut
get, you
it
don't get to call
out.
the shots, man.
No,
I'm the director.
Ask the director.
Okay.
I'm the director.
Can I just
Right.
start after perinatal death?
Director says no.
Dang.
This is so.
I hate you.
So the takeaway is.